entity as part of our plastics. Elsewhere, right in our neighborhood, with a very well specialty, subspecialty is part of our plastics. But we have here now introduced aesthetic as part of our plastics at Al Shifa Trust Eye Hospital, Kandy. Today we have a session where faculty from aesthetics are talking about the various procedures, and Dr. Ghazan will be acting as moderator. We are expecting Dr. Zishan coming as co-chair, but I can't see him around. I hope we can start now. Time we have to see what the announce आपका session शुरू हो जाएगा. फिर हमें कोई choice नहीं. Assalamualaikum everyone. I'm Dr. Faizan Tahir. I welcome you all to our session on aesthetics. So without any delay, may I call Dr. Karina Temu to tell us something about Botox injections.
My name is Dr. Karina and today the topic I'm presenting is the marking of the Botox injection. So Botox remains the most popular non-surgical aesthetic intervention worldwide. Yet, for optimal results, we need to know the anatomy and the techniques also matters. So, a thorough understanding of the facial anatomy and the muscle dynamics are very important. By the muscle dynamics, we mean not only knowing the anatomy and the function of the muscle we are treating, but also knowing the dynamics of the muscle, which is antagonistic to the muscle we are paralyzing. Because by paralyzing a muscle, you are disturbing the dynamics and the pull of the muscle. So the antagonistic muscle will be comparatively stronger and that will affect the result. So today we are going to touch upon three areas: the forehead lines, the frown lines, and the profiles. So first, the forehead lines. Forehead lines are caused by the frontalis muscle. Frontalis is the thin muscle that starts from the glea erotica and the fibers runs vertically down, inserting around the eyebrow skin and on the auricularis. So the pull of the muscle and the direction of the fibers are vertical, but they cause horizontal wrinkles. Wrinkles are always perpendicular to the pull. So first, we will discuss the no-go zone for frontalis. When you're treating the frontalis with the Botox, do not treat the lower third. Why? Because frontalis is the only muscle responsible to raise your eyebrows. While there are quite a few number of eyebrow depressors, which are auricularis, procellus, corrugator, and depressor superciliary. So if you treat whole of the frontalis, you will end up with the eyebrow drooping or eyebrow ptosis, which will not be aesthetically acceptable by the patient. So how to mark for the forehead line? First, you have to mark the lateral edges of the muscle. For that, you have to ask the patient to raise the eyebrow. So the lateral edges are marked where your wrinkles are ending or where the height of the eyebrow is zero. So these are the lateral edges of the frontalis muscle. Then you have to mark the no-go form. So this is the no-go, you don't have to treat below that. Then in the upper part of the frontalis, make a box like this and you have to mark 5 points on the margins. The upper center point is usually not treated because that is the aponeurotic part. So there is no use of giving Botox in the aponeurosis. So these are the initial 5 points you will mark. And if you do not treat the lateral edges of the frontalis muscle, you can end up like this with the high arched lateral eyebrows because the lateral frontalis will pull them upward. This is called Mephisto sign, which is of the name of devil in Marvel comic who has this kind of high arched lateral eyebrows. So to prevent this, you have to add 2 points on the upper lateral edges of the frontalis muscle. So these are the points for the treating the forehead lines. After marking the points, the depth should be superficial here because frontalis is a thin muscle, and the dose should be 2 units as the start, 2 units on each point. You can always ask your patient to come after 3 days for the top. And the key point you have to remember is to don't treat the lower third of the frontalis muscle. For the frown line, the two muscles mainly responsible are the corrugator superciliary and procerus muscle. The corrugator superciliary starts from the upper medial socket, it goes upward, inserting on the skin of the eyebrows and skin above the eyebrows, while the procerus is a triangular muscle originating from the nasal cartilage and nasal bone, fanning outward and upward, and is inserting on the skin of the lower third of the forehead. So, to localize the muscles, first you have to ask the patient to frown. This sign, 11 sign, we always call the procerus muscle. It is a strong muscle, and to knock out this muscle, you have to mark a single point in the center of the glabella. To be more specific, you can draw a line here, joining the two medial canthines, and then a straight line dissecting it. And you have to stay here on that line. And the level should be on the lower quarters of the eyebrows. Then you have to mark the corrugator. Corrugator starts medially from the procerus, and it goes laterally. This is the corrugator. How can you mark the lateral edge of the corrugator? Is by these V-shaped stretch mark, or you can draw a line at the mid-pupillary level. So the lateral edges end at the mid-pupillary level. So for corrugator, you have to mark 2 points, one for the medial corrugator and one for the lateral, in the tail of the corrugator. The depth here for procerus and for the medial corrugators are the deep intramuscular injection. You have to hold the muscle and give a deep injection. While you have to stay superficial for lateral corrugator, because one, the lateral corrugator is inserting into the skin, and secondly, below the lateral corrugator are the fibers of frontalis which you have to avoid. Dose is 3 to 1, 3 for procerus, 2 for medial corrugator, and 1 for the lateral corrugator. And the key points you have to remember are stay at least 1 centimeter above the rim which you are when you are working on the upper part of the eyebrow. And second is avoid excessive deep lateral injection, again to prevent the eyebrow process. The last one is the crow's feet or lateral canthal lines. These are caused by the orbicularis or ocular muscle. Orbicularis oculi is the circularly running muscle, so the lines are perpendicular and fan out laterally. For orbicularis, you have to mark your first line from the lateral canthus, which is of 2 centimeter in length, and a straight line from here. And your first point is where the 2 lines meet. And then you have to draw 2 lines going diagonally upward and upward, and the other points are on these lines. The pattern of these points corresponds to the circularly running orbicularis muscle. Here you have to be careful that you have to stay lateral to the lateral orbital margin, not too lateral that you miss the orbicularis fibers, and not too medial that you end up with the botox going into lateral rectus muscle. The depth is superficial. The dose and the start is 2 units on each point to 6 units on each side. And the key point to remember is direct your needle away from the orbit when you are injecting and stay lateral to the orbital. So the take-home message is the 3 pillars of perfect botox marking is you should know your anatomy first, avoid the danger zones, and know the anatomy of the muscle you are treating and the anatomy of the antagonistic muscle. And mark with attention, every point you are treating should have a purpose, and treat with restraint, because you can always ask the patient to come after 3 days for a top-up rather than living for 3 months with the same outcome. Thank you.
Thank you very much, Dr. Nirmala. That was a wonderful presentation, highlighting not just the botox but periocular anatomy.
Kindly keep your questions safe till the end, inshallah, we will have questions. Inshallah, we are running quite in time, so we will have time for questions, inshallah.
So next, may I call Dr. Sumaya Ali Khan to present on the science behind PRP generation. Dr. Sumaya is an assistant professor in oculoplastics department at Al Shifa.
Apart from Botox is platelets. And so I will be talking about whether the platelets is a hope or a hype. Because it has been met with a lot of skepticism that it's something that may or may not have its effect. But we'll show today, and the presenters after me, are case series of patients who have benefited greatly by injections of platelet-rich plasma into the periocular area. So I will just briefly talk about how it came into use. Platelets and platelet derivatives have been quite a hype for the last 5 decades. But the idea of intentionally creating inflammation actually prompts the body to start the healing process. It was understood centuries ago by the Roman writer Celsus. And then Dr. G. Hackett was the pioneer of doing this sort of treatment and teasing the damaged ligaments. And he noticed that when he injected things into the ligaments and the tendons, patients had a better recovery. So PRP injections also work on a similar principle. They offer a double benefit. When we are injecting, so we're actually causing trauma, and that induces inflammation, and then we supply the inflammatory mediators to that area. So in damaged tissue, scar tissue, burnt area, or aging tissues, the whole pathology is that the blood supply to that area is not much. So the body's own anti-inflammatory things and collagen-producing agents are not able to reach that area. So what we do is we help. We take the patient's own plasma and all those magical microgranules and we put it in the area which needs it the most. So this is harnessing the body's own healing power. So platelet granules have a myriad of growth factors: keratinocyte growth factor, platelet-derived growth factor, red gel, fibroblast. All of these factors we've read about. And this is just a brief history for interest's sake that they were discovered. EGF was discovered in 1962, PDGF and our favorite VEGF in 1989. But when was it formally used for the healing of skin? The first largest RCT that we came across was published in 2007 because the studies are not very standardized, the study groups are very small, so it was met with skepticism. They use platelet growth factors in treating wounds and soft tissue injuries. So, then it was used by maxillofacial, it was used by orthopedic surgeons, and it was then finally tried in ocular areas as well. PRP can stimulate all of these collagen synthesis, deep dermis and subdermis, soft tissue augmentation, activation of fibroblasts, new blood vessels, adipose tissue formation. So it has a lot of uses at all branches of medicine. It has been, as I mentioned earlier, in orthopedics for injuries as well as for osteoarthritis, alopecia, tendinitis, maxillofacial areas, in gynecology even, and for bone grafts as well. So the role in ophthalmology is multiple uses for dry eyes, for corneal wound healing, for post-refractive surgery, dry eye syndrome, for retinitis pigmentosa, for graft contracture around the eye and dry AMD. So because this is not a pathology session, this is an aesthetics session, so I'll be telling you about how we use PRP for aesthetics. So periocular aging is because of 2 reasons, volume loss in the area and gravity. Both of these work towards thinning the tissues and bringing the fat down. So PRP injections produce periocular rejuvenation, usually under eye bags, fine lines, hyperpigmentation, hollowness, scars, and burns. So the future directions. What is the future? So this has been, PRP has been tried in the periocular area. We'll be presenting a case series of patients who are benefiting greatly by PRP injections into their scars on the lid. The future directions are novel delivery systems. They're making little pellets of PRP which can be placed in the patient's subdermal area, and that can produce sustained release of platelet-rich plasma. PRP plus tranexamic acid and exosomes are being tried for melasma treatment. Personalized PRP treatments are in the way. They want to find out which patient is going to benefit how much from these injections, and they are under process. and utilizing artificial intelligence to analyze patient data and predict best PRP formulations for specific conditions. Now, there are obviously drawbacks, and one of the reasons why it was met with skepticism was because it needs a proper laboratory structure, which a lot of clinics don't have. It needs physical conditions with the right equipment, experienced teams, well-designed protocols, because it is, after all, a biodegradable product. It is difficult to compare results among studies and conclude on better solutions, and we need to be aware of the concentration for the particular usage. So I'd like to highlight, so for tendon injuries and for bone injuries, they use platelet concentration, 3 times the concentration in normal blood. We don't need such high concentrations in the periocular area, but we need to know our centrifuge settings for that. So I conclude by saying that the art of medicine consists in amusing the patient while nature cures the disease. So this is just our little attempt of harnessing the ability of nature to help us. Thank you.
Thank you, Dr. Sumaya, for highlighting the role of PRP in ophthalmology, specifically in aesthetics. I think we all want to know how the PRP is actually prepared. And for that, may I call Dr. Amna Manzoor to give us a presentation.
Assalamu alaikum, ladies and gentlemen. I'm Dr. Amna Manzoor, and I'm working as Associate Professor in the Department of Ophthalmology. And today I will be presenting PRP. My topic is PRP from wire to vitality. So there is no financial disclosure to it, and all the patient photographs that have been shared after their passing. So I'll be touching upon these points, that what is PRP, how the sample is collected, centrifugation steps, and other things about PRP. So basically, what is plasma-rich, platelet-rich plasma? So basically, the plasma contains electrolytes, nutrients, water, and proteins, which are immunoglobulins and complement factors, along with the growth factors. Whereas the buffy coat, which is right here, it contains the white blood cells and the platelets. So next is the sample collection. First of all, we do about 30 to 60 ml of venous blood into triacetic citrate anticoagulant tubes, and the temperature should be maintained at 20 to 26 degrees Celsius, and chilling should be avoided. And we should always label and record the baseline CBC of the patients. So in our experience, centrifuge should be done at 3000 RPMs for 15 minutes. And the outcome is at the end that there is a layered blood with the RBCs at the bottom and buffy coat in the middle, and there is plasma with the platelets on top. So after centrifugation, what happens is that the platelet core plasma along with the buffy coat that is separated in syringes for application into the scar tissue. So now coming on to the methods of injecting PRP, there are 2 or 3 types of methods that we can use PRP. One is that we can inject it directly into the scar. So PRP can be injected directly, but this is a rather crude method, but it is one of the most effective methods. And patient experiences a lot of pain while injecting, but the results, they are worthwhile. The next is derma-pen microneedling. So PRP can also be delivered to the scar tissue via a derma-pen, and the needle lengths, they range between 1.5 to approximately 2.5 millimeters. And the PRP reaches the dermis via the micropunctures that are given with the derma-pen. Next is that it can also be injected before grafting onto the patient. So it acts basically as a wound modulator, and this helps to prevent the graft contracture post-operatively, and the results are excellent. So now coming on to our experience at Al-Shifa Trust and Hospital. So this is a patient who was referred to me from Sabah, and he had a road traffic accident, and he had acquired a scar that was extending right here from the upper leg, extending into the brow and up to the forehead area. And this scar was causing him an upper leg. So this scar, it was giving him an ectropion, and there was lagophthalmos as well. So what happened was that I injected him 3 times PRP for 3 months. And at the end of the day, what happened was that his ectropion, he got relief from that. And instead of doing a graft in this patient, he had ptosis at the end of the day. And I ended up doing a levator resection with a mild blepharoplasty in this patient. Similar such cases we are also doing. This is also a similar patient who had ectropion, as you can see, and the scar is also extending up to his forehead. And after PRP, you can see that his lab of thalamus has much improved. So this patient also presented to us with an upper lid notch right here, along with there was lab of thalamus as well, and this was post RTA, and he was given PRP injections, which and his lab of thalamus improved to such an extent that he did not need graft, and he only repaired his notch, and he did not require a graft at the end. So similarly, this patient's lab of thalamus, as you can see in this picture, that it has also improved and he does not require a graft. So, the best aspect of this procedure is this, that 100% of the patients, they have reported improvement in their appearance and mobility of function. So, at the end, I would conclude that PRP offers a very safe and a very biologically driven boost to the periocular scar outcomes. And I would like to recommend all the oculoplastic surgeons here to start injecting PRP before jumping to grafting in a patient who has got superficial ectropion along with lab of thalamus. Thank you. Yes. Yes, but the patient is so happy at the end of the day. The results are so good that now the patient says it's okay, I can bear the pain. Because you see, the graft thickness, it decreases to such an extent that he can actually feel it. And second, if the patient is, if his threshold is very less, so what you can do is you can go for dermapen. No.
The results actually make the patient forget the pain. That's what the conclusion.
Next, please. I think, can you please keep the questions till the end?
Yes.
We will have time, inshallah. We will
How
have
much wait
time.
for the result?
1 month, within 1 month, the patient comes back by himself and he says that I want to go ahead with the second. So there are patients in whom we have given even 6 sessions, and they come willingly for this.
Must be. Yes.
So actually, if they are taking the question, what tests you advise before you give PRP?
So as such, no tests are done, but what we can do is CBC and because it's the patient's own blood that we're injecting, so there's no specific test that needs to be done.
Thank you.
Right. Thank you, Dr. Peter. Dr. Sandra Ahmed will present on safety and complications in aesthetics. Dr. Sandra is a fellow in orbit and oculoplastics at Al-Shifa.
Assalamu alaikum everyone. So we all know that non-surgical periocular rejuvenation is very common these days, but not to forget that it can also have some complications. And today I'll be discussing about those complications and what preventive measures can be taken to prevent those. So generally these are considered very safe, but the term minimally invasive is sometimes used very casually to the patients, and the patients assume that minimally invasive also means that these procedures have minimal risk, which is not the case. Minimally invasive does not mean that these procedures are also having minimal risk. So these also sometimes oversimplify the procedure to the patients, and the patients think that it's okay to go ahead with them and they are not going to cause any complications. But there are some complications. Generally, these are safe. So in 90% of the cases, the patients do not report with any permanent complications. But there are few which we'll be discussing today, mainly of dermal fillers and botulinum toxin injections. So talking about dermal fillers, there are many kinds of dermal fillers, but the most commonly used in periocular area is hyaluronic acid. It's a naturally occurring element, so the complications are usually less because it's not going to cause any allergic reaction. But still, I'm going to discuss a few. So these are the areas where we use periocular dermal fillers. Most commonly, as Dr. Fajr has already highlighted, it's used for the forehead lines, for crow's feet, for frown lines, and for eyebrow lifts. And, sorry, I forgot, teardrop. So to overcome the shallowness of the infraorbital area, to provide fullness in the temples and for frown lines. So there are ischemic as well as non-ischemic complications. Non-ischemic ones are very common, but the most dreadful ones are the ischemic complications, including stroke and necrosis, skin necrosis, and vision loss. So I'll just be sharing a few of them. Hematoma is very common. Usually it occurs due to puncture of the vessels, but it can be sometimes delayed due to the external swelling that is present at the moment. The patient can present later with the hematoma. And how can we prevent them? Immediate direct pressure can reduce the hematoma size. So as soon as you see it, you can just press it and it's going to decrease the size. But obviously it resolves on its own and it takes around usually 5 to 7 days. Nodules and lumps are also very common. They can be early as well as late. So early nodules can be prevented by they happen when we inject large boluses of injection or when the injector places a lot of pressure on the skin. While delayed nodules and lumps occur usually from 1 month to a period of 1 year, and there are many mechanisms for delayed lumps, but most common being that hyaluronic acid breaks down with time. So these tiny particles are then presented to the immune system later and then they cause delayed inflammation. So to prevent that, obviously again injecting very slowly, avoiding large boluses, but there is a reversible mechanism and that is injecting hyaluronidase. So it's going to dissolve all the hyaluronic acid which has been present for a year. So that I'm talking about delayed lumps. A patient presents after a year with a lump, you can always offer hyaluronidase. Tendon effect occurs when the injection was too superficial and too much of the dose was used. So this is basically bluish discoloration, and you can appreciate here. So this happens when the injection was too superficial and the blue light causes scattering from the skin and results in bluish discoloration. This can be prevented by being a little deeper, and to manage this, obviously makeup can conceal it. But again, if the patient is very much concerned, hyaluronidase can also be used to dissolve the infection. Okay, malar edema occurs in 11% of the patients. This is again one of the most undesirable effects. So usually happens when the dermal filler was given in the beard duct area. So what happens is that normally there is a structure called malar septum, which is a facial structure which originates from the inferior orbital margin and extends into the mid-cheek dermis. So this facial structure is dividing the suborbicularis ocular tract into two compartments, superficial and deep. So when the injection was given too superficial, that is above the malar septum, you block the lymphatic drainage and this results in malar edema. So to prevent this, the injection should be number 1, deeper to the septum, and number 2, you can always give hyaluronidase. Let the swelling settle for around 2 weeks. The patient comes back again and hyaluronidase can be given. So allergic reactions, as I told earlier, they are not very common because hyaluronic acid is naturally occurring in the environment. But we can still encounter them, including immediate and delayed. So immediate happens when the HA is exposed. Hyaluronic acid causes release of histamine, which results in edema, erythema, pain, itching, and this can be easily managed by giving oral antihistamines and steroids if refractory. But the delayed one, which is usually type 4 immune reaction, it happens after 1 to 3 days, and for this, oral antihistamines do not work and steroids needs to be given. But if the reaction is causing a lot of discomfort to the patient, hyaluronidase can again be given. Now coming to the vascular complications, these are the most dreadful ones. So first is skin necrosis. So this occurs when there is arterial or venous obstruction. How can this happen? When accidentally you inject the injection into a vessel or external compression of the vessel by the filler or by direct trauma to the vessel wall. The incidence is only 0.3%, but as you can see, it's very unsightly and the patient presents with a lot of pain and blanching, and within few minutes to hours you see a bluish discoloration. So treatment is again immediate and hyaluronidase should be given as soon as possible. And the most devastating of all is the vision loss. This is a case of Taiwan. This occurred in 2019. So this patient had a dermal filler in the forehead, and within few hours it presented to this facility with vision loss. The patient also developed third nerve palsy. You can see there is ptosis, there is exotropia, and there are puncture wounds on the forehead. So the primary care provider, they try to puncture it so that they can take most of the HA out of the patient, but by that time vision loss had already occurred. So till now, only from 1906 to 2019, only 190 cases have been reported of vision loss so far. Most of them were by autologous fat implants, not by HA. But still, this can happen because of the retrograde flow of the hyaluronic acid into the arterial system. This can block the vessels, this can cause ischemia. So the dangerous areas are glabellar area, nasal region, nasolabial fold, and forehead. To manage, there's so many things which can be done, IOP lowering drugs, steroids, but the prognosis is generally very poor. So the main aim should be minimizing the risk of vision loss, which can be done by number one, injecting negative aspiration, injecting very slowly, and keeping this in mind that many experts can also result in this vision loss accidentally. So this should always be in mind and always convey to the patient as well. Now coming to the botulinum toxin injections, these are comparatively safer as compared to the hyaluronic acid, and in ophthalmic practice they have been used for benign essential blepharospasm and strabismus for quite a long period of time. But they are also used for non-surgical periocular facial rejuvenation, and mainly these are addressing crow's lines, crow's feet, frown lines, and forehead lines. The major advantage or the plus point of botulinum toxin injections is that the effect usually wears off with time, so it does not have any long-term sequelae. The complications can be divided into common, less common, and rare ones. So common are usually redness, swelling, and you experience this at the time of the injection even. So redness, swelling, small burns, all of these can be prevented by using fine needles, for example 30 gauge needles, by cleaning the skin gently, and by avoiding large doses. Cold compresses can be given if the patient experiences such kind of bumps, and you can always tell the patient that it resolves usually with time, so these are not very significant. And another one is bruising. To avoid this, you have to ask the patient to avoid any NSAIDs, any steroids, and vitamin E for the previous 24 to 48 hours before coming for the injection. And management is again, ice compresses can be done, and reassurance obviously, because these also resolve within 5 to 7 days. Headache can also occur, especially if you are given around the glabellar area. But the surprising point is that patients having migraine, they start feeling better after having botulinum injection in the glabellar area. So headache also resolves with hydration and rest, and usually lasts for only 24 to 48 hours. Now coming to the significant ones, these are less common, but these are very bothersome to the patient. One of these is ptosis. So a patient comes to you and he has frown lines, or he has crow's feet, and he goes back with the ptosis. So obviously that's not a very good sign. This happens when the dose was large or the injection was too deep. And immediate sign is that if you see a swelling or bruising post-injection, it means that you have gone deep and the patient might come with ptosis. So this happens when the botulinum toxin spreads by diffusion into the levator pelvis superioris, which we do not want, and then it results in ptosis. So to prevent this, at least 1 to 2 centimeter above orbital rim should be your area of injection. Minimal dose should be used, and you have to stay in the midline area. Patient should be counseled not to rub the eyes and not to do any vigorous exercise for 3 to 4 days following the injection. And to manage this, epinephrine drops 0.5% are used, but they are not available in Pakistan. So you can ask the patient to wait for spontaneous resolution. The toxin starts wearing off in 2 to 6 weeks, so it's not much of a period of time. So the patients usually can wait till that. Another one is brotosis, and as it was discussed in the previous presentation, that frontalis area is very risky in a sense that if you encounter and inject in the central lower zone of the frontalis, it can cause brotosis. So frontalis action is to pull the eyebrows, and then you relax it by botulinum toxin, so it causes brotosis. It's not very clear in this picture, but if you observe, there is heaviness and there is fullness in this area. It has resulted in brotosis as compared to this one. And to prevent this, again, injection should be given 1.5 to 2 centimeters
above the eyebrow, and one should always start with conservative dosing. That means that you start with a minimal dose and see if your patient responds to that. If does not, then you can increase or top up after a few days, but do not start with the maximum dose. And every patient obviously responds differently, so you can start with the conservative dose. To correct this, Botox can be given to the adjacent muscles, like antagonists we were talking about, but that should be done after around 15 days. So you wait for the 15 days, let this effect sink in properly, and then you can inject botulinum toxin in the adjacent antagonist muscles. Now, rare ones are diplopia. This can happen when somebody is injecting in the medial part of the lower lid and they have been using very inappropriate injection techniques. This means that they have gone and diffused the injection into the inferior orbit. So the patient comes with diplopia and pain on eye movements. So to prevent this, injection should always be given in small doses. And you must know the anatomy of the lower lid and the orbicularis muscles and the extraocular muscles so that it does not happen. Patient can unfortunately only be offered occlusion because you can only wait for three months for it to wear off. The last one is lower eyelid laxity and ectropion. This happens when you inject a lot of dose in the inferior orbicularis muscle, which weakens the orbicularis and causes sagging. So both botulinum toxin and itchy fillers carry predictable patterns of adverse outcomes, both of which are preventable. And using such simple techniques like using a cannula instead of a needle in high-risk areas, using finer needles, using smaller doses can prevent all of these complications. Thank you.
Thank you, Dr. Sandra, for giving us a detailed account of the risks and potential complications related to periocular injections. So this was our last presentation. The house is now open for all the questions.
So if we know which muscle has been diffused by the injection, then we can inject on the other. Like medial rectus has been involved, we can inject in the lateral rectus, just like we do for the sixth nerve palsy, third nerve palsy, and to avoid the 3 months or 6 months patching and this psychosocial problem.
So what the house says about it, antagonize the paralytic effect. Do you think anyone has experience, or is there anything you have gone through in the literature?
No, just
It's a brilliant idea.
2 weeks ago, I put this Botox 10 units in a patient with 6 nerve palsy.
Okay.
I put it in the middle.
You are using the same principle here.
Yes. So this is an idea pop-up. If the patient can page for 3 to 6 months, there should be something that we can do.
That's an excellent practice. Also, sometimes.
But how will we the areas that we are injecting, usually the muscles are not involved except for the inferior orbit, which is right so medially. So injecting the superior oblique would be because it's not usually the recti that
You have to go behind the orbital septum in order for any of the other extraocular
muscles to be affected. So it's not like you're inducing some palsy. It's only the inferior oblique usually that can be affected when you're giving the injection inframedially. So that's not a possibility.
And we cannot
Then you can
inject
antagonize its antagonist.
and we cannot inject into the superior oblique. Why not?
How do you inject it? Not a paralysis.
You inject the antagonistic muscle to or deviate.
Any other questions, please?
Yeah.
Questions?
Honest, and it's a very specialized fusion of ophthalmology and aesthetics. And the services we are giving are one for purely aesthetic patients or clients, which includes injectables like PRP, Botox, fillers, microneedling, including RF microneedling and developments, lasers, CO2 lasers, cannula lasers, carbon spectra, infusomes, and HIFU procedures for fat lipid dissolving injections. And second, we are in collaboration with oculoplastic patients like Dr. Amna showed you the scar patients, the periocular scars, and dry eye patients. And our third, we are also running an ocular oncology clinic under the umbrella of oculoplastics. So the post-chemo patients, which when they need help aesthetically after their medication, the dermatological and then rehabilitative and scalable. So we are starting to.
We have dermatologists, a qualified dermatologist doing as well. So we have a combination of ocular aesthetics and general aesthetic as well, but we work only on face. So that is the unique characteristics of and features of our clinic at Al Shafa. I can't invite people from Lahore over there, but those who are from Rawalpindi and around, they can utilize services of our at Al Shafa. Thank you very much. If there are no questions, now we will have a group photo of all the speakers. Please. Thank you.